So bones, biopsies, and cultures from our BBC correspondent. So let's start with the news. So there's supposed to be some audio with that. There we go. So those of us who live in the UK live and die by the BBC News. And here I am at the BBC headquarters, and we're going today to do the BBC Cultured News to get you a little more sophisticated than the programs that are normally on that station. So let's move ahead and think about bones, biopsies, and cultures. I want to begin with a human interest story because that's what the news people always do. This is actually a true story, Dateline, Boston, USA. In 1940, after suffering ill health for years, Professor Otto Plath, a world expert on bees, was forced to see a doctor for a foot infection. The doctor diagnosed his chronic illness as diabetes, now so advanced that it threatened his life. Otto's leg had to be amputated after he developed gangrene. He continued to decline in the hospital and died a month later. When his 8-year-old daughter Sylvia was informed of her father's death, she cried, "I'll never speak to God again." This, of course, was Sylvia Plath, Pulitzer Prize-winning poet and author. I think this just gives you a flavor of what diabetic foot problems are all about. Let's begin with the culture part of my assignment. I think any of you who've heard me speak about diabetic foot infections may have seen this slide where I rail against getting culture specimens by swab as opposed to getting tissue or doing an aspiration. And I'd like to present some new data that suggests that there's more of a scientific basis for that than we had previously. We did a study in Istanbul in Turkey looking at a group of 89 patients for whom there was paired cultures of both swab and tissue. And you can see here the comparison of the swab against the deep tissue. And you can see that the positive predictive value of 84% and the sensitivity of 79% aren't too bad. But if you look at the negative predictive value and the specificity, they're quite poor, leading to an overall accuracy of only 73%. And when we went back and looked at each of these patients, what we found is that if the physician had followed the results of the swab culture in 1 out of 3 cases, he would have given the patient the wrong antibiotic. Now, bringing more science to this area, Dateline Leeds, UK, is the Concordance in Diabetic Foot Ulcer Infection, or CODIFY study. This is a study that we've just completed. It enrolled patients with infected diabetic foot ulcers recruited from 25 sites in England. The primary endpoints are agreement between wound swab and tissue specimen for 3 microbiological findings: the presence of likely pathogens, the number of isolates per specimen, antibiotic resistance of isolates. We have some secondary endpoints, including the appropriateness of empiric antibiotic therapy before the culture results were back, adverse events and costs of the 2 collection methods, and we're doing a subset analysis looking at PCR versus culture methods. I can give you some preliminary results. Andrea Nelson, the PI on the study, has given me permission to release this information. We met our goal of enrolling 400 patients. Overall, there were 79 different microorganism types isolated from the specimens. 35% were noted in more than 1% of the samples. Looking at the organisms that grew, no big surprises. Gram-positive cocci in 70%, gram-negative bacilli in 37%, anaerobes 21%. Interestingly was the category of mixed or normal flora or enteric or fecal flora. These microbiology lab reports are pretty useless to us as clinicians, and virtually all of them came from the swab specimens, not from the tissue specimens. So, Dateline the world, and you can see this culture plate represents the way we would think of the cultured news. Looking at gram-negatives in diabetic foot infections, more recent studies of microbiology are coming from Asia and from Africa, and one of the important things that they're showing, as this paper from Vijay Viswanathan is showing, is that gram-negative infections are much more common in people with diabetes than in those who don't have diabetes. The prevalence rate of gram-negative rods in diabetic foot infections in Asia, particularly in India, is somewhere between 25 and 68%, depending upon the study that you look at. They also have very high rates of multi-drug resistant organisms among these gram-negative isolates. And Vijay brought up the issue that this raises questions about the need for change in the policy that we use for selecting empiric antimicrobials, because up to date we've been looking at mostly covering aerobic gram-positive cocci, which I believe is true for North America and for Europe, but may not be true for Asia. Well, we thought about this for a while and came up with an idea. Dateline Istanbul, Turkey. We thought we would look at what's going on the microbiology of diabetic foot infections in Turkey. And we published this paper just a few months ago. Why Turkey? Well, if you look at a map of the world and you see Europe positioned as it is and Asia positioned as it is, right at the crossroads of the two is, of course, Turkey. And if you look at the microbiology from selected studies throughout Europe, gram-positives are present in about 70%, gram-negatives about 20%, and specifically Pseudomonas. Why Pseudomonas? Because that's the one that all residents in the hospital think you have to treat when you have a diabetic foot infection. And no matter how often Warren, Joseph, and I say that it's not necessary, they continue to use vitamin Z, as we call it, or Zosyn, to treat many diabetic foot infections. It's present in a small minority of patients. If we look in Asia, on the other hand, looking at a number of recent studies, gram-positives in about a third, gram-negatives in just over half, Pseudomonas is much more common. So what do you see when you look at Turkey over the last 20 years? A systematic review of all of the studies right in the middle. About 50% gram-positives and gram-negatives, and about 15% of those gram-negatives are Pseudomonas aeruginosa. So an interesting little study. Now, in terms of microbiology, the future is going to be very different from the past. And the reason for that is that cultures, which we've traditionally used for the last 150 years, usually require several days for results to grow. They fail to grow many organisms, especially anaerobic organisms, and they often are falsely positive in patients who are receiving antibiotic therapy, which a great majority of patients are by the time they are admitted to hospital. What's the future? Molecular methods. And I've taken out most of my slides on this because I know that the next talk is going to be about the new molecular microbiological techniques. But I'll simply summarize by saying that these methods are going to be faster. They're going to identify more isolates. They're going to provide us with some quantitative, not just qualitative data. They can allow us to identify virulence factors and, in addition, can pick up on antibiotic resistance genes. Now, I'm going to switch to the one of the B's, the bone side that David assigned me. So I'm going to talk with you about some new issues that have come up in the last few years in studies of diagnosing diabetic foot osteomyelitis. As you know, there are a variety of clinical things that we can do to help determine which patients with osteomyelitis, which patients with diabetic foot problems have osteomyelitis. There are features in the history, features in the physical examination, the probe-to-bone test, which, if done correctly and interpreted correctly, can be very useful, and there are blood tests. Among the blood tests, the most useful turns out to be the erythrocyte sedimentation rate, which, when above 70, is highly suggestive of osteomyelitis, and it can also be followed over time to show whether the person appears to be responding to treatment of their osteomyelitis. We, of course, also have imaging tests, which include plain X-rays, which have limited sensitivity early on and limited specificity late. Radionuclide scans, bone scans, are pretty useless, but a white cell scan, if you can't get a MRI scan, may be helpful. MRI is considered the best of the current advanced imaging tests. If you need one of those, we're usually looking for bone marrow edema and soft tissue abnormalities such as sinus tracts. But there are a variety of new techniques in the imaging world, and in particular SPECT-CT, PET, and PET MRI. And I want to take us to a Dateline, Paris, France, for a study that we did there, looking at single photon emission computed tomography with computed tomography. So it's gallium-67 SPECT-CT. When you look at a CT scan, you get very nice anatomic imaging, but you don't know anything about the functional state of what's going on or the metabolic activity. Add gallium-67 and you can begin to see there's a hot spot right there on that bone in the lower right-hand side, and that's where you put your needle to get a piece of bone that's likely to be infected. Now, we did a study on a group of 55 patients in Paris, and we came up with the concept that if you did a SPECT-CT scan, if it was negative, then we thought it was highly likely that the patient didn't have osteomyelitis. And in those patients, we didn't give them any antibiotic therapy, and 13 of them went on to be cured. If they were positive on the SPECT CT scan, the next step is to do a bone puncture for a culture, and we did that on those patients. If they were negative, again, no antibiotic therapy, and all but one who died were cured. If it was positive, then you can see that we went on to use culture-directed treatment for the osteomyelitis and had pretty good outcomes. So overall, looking at the results here, the combined method shows very high sensitivity, specificity, positive and negative predictive values. So we think this is an interesting sequence of events that Elizabeth Asselin-Gould has been using in Paris with very good results. Now, I want to talk about an approach to diagnosing diabetic foot osteomyelitis that emerged from a meeting that I went to in Milan, Italy, a little over a year ago. Andrew Bolton had asked me to be the EASD representative to this meeting, mostly because I think he just didn't want to go to a big nuclear medicine meeting. And what we did was to look at all of the data on the diabetic foot and come up with a sequence of events of how you might want to diagnose osteomyelitis. This appears to be a somewhat complex chart, but actually it's a real simplification from what the nuclear medicine people started with. We essentially thought you could start with plain x-rays. If they were highly suggestive of osteomyelitis, you need go no further. If, on the other hand, you had equivocal results, we think you should do an MRI. If the MRI has equivocal results, that's the one place in which we thought we could all agree that some form of a nuclear medicine scan, like a SPECT CT or possibly bone marrow scintigraphy, would be helpful. And you can look at this publication if you wish to get a little more detail. This has not yet been subjected to any validation, so all I can say is I present this as something that infectious disease, nuclear medicine, diabetes, and radiology all agreed upon as a reasonable scheme. Now, I want to speak a little about gram-negative osteomyelitis, a study that we did looking at patients from the Gran Canaria Islands in Spain. We looked at a group of patients who had gram-negative osteomyelitis and compared them against patients who had non-gram-negative osteomyelitis, and shown in red are the changes that are statistically significant. And when you do a logistics regression on this, what we found is that among the 44% of patients who had gram-negative organisms, there was a statistically significant association, independent risk factors of increased severity of infection, increased white blood cell counts, decreased hemoglobin A1C, and a history of a traumatic wound. So there appear to be some clinical characteristics that might point you in the direction of saying I might be dealing with a gram-negative osteomyelitis. Now, in Turkey, returning to Istanbul, we did a study looking at patients hospitalized at one medical center for diabetic foot infections over 2 years. And we were interested in, does it matter if you have diabetic foot osteomyelitis? And what we did was to compare the patients, 37 with osteomyelitis and 36 without. These were all diagnosed by positive bone cultures. And you can see these are the significant differences between the groups. Length of hospitalization, significantly longer. Duration of antibiotic therapy, not surprisingly longer. Duration of IV therapy, longer. Duration of the wound before the patient presented was longer. The need for surgical procedures, the time for the wound to heal, and the need for minor amputations. So it looks as if, as one might guess, the presence of osteomyelitis is associated with a whole variety of adverse outcomes. Now, in the Diabetic Foot Study Group meeting last fall in Sitges, Spain, so we're at Dateline Sitges, Spain here, there was a debate about a very hot topic, which is surgical versus medical therapy for diabetic foot osteomyelitis. We've always thought that you needed surgery for most of these patients, but more recent data suggests that properly prescribed antimicrobials alone may be sufficient. So there was a debate between Fran Game on the medical side and Javier Aragon Sanchez. And here are our gladiator contestants, remedium and chirurgia, the Latin terms for medicine versus surgery. Sorry, Fran, I forgot to cover up here. And I was asked to be the mediator between these two, and they had a very interesting debate. It was very popular. The outcome was that we thought it was probably pretty much a tie. Fran cheated a bit because she presented a case and said, "What would you do if this was your mother?" And it turned out it was her mother, and she had a photograph of her. And so, but overall, we felt that What needed to be done was a randomized controlled trial, and that what is actually has been done. So if you looked at diabetes care a couple of months ago, you will have seen a paper from Madrid and from Gran Canaria comparing a randomized controlled trial of moderate diabetic foot ulcers without necrosis and patients proven to have osteomyelitis. They were randomized either to antibiotic therapy or to surgical therapy. Now, it's a little bit of a misnomer because the patients who got antibiotic therapy certainly got 90 days of antibiotic and no surgery, but the patients who got surgery did get 10 initial days of antibiotic. If you follow them through, and I won't go through the details, but get down to the bottom line, in green, the percentage of patients cured, 75% with antibiotic therapy, 86% with surgery. No statistically significant difference in this relatively small group of patients in the percent cured, the time to cure, and the complications. What's remarkable about this study is that it was done at all, and it was very difficult for them to enroll enough patients, but it certainly is suggestive that antibiotic therapy alone appears to be as good as surgical therapy. Andrew Bolton asked me to write an editorial about this article, which I did, and I wanted to just show you a couple of tables that were in that editorial. The first looked at the potential advantages and disadvantages of both surgical therapy and medical therapy for treating diabetic foot osteomyelitis. And you can see that under the surgical side, it has a number of advantages, removing necrotic bone, getting rid of bony prominences, and having an opportunity to stabilize the foot. But there are certainly a number of disadvantages, which include increasing the risk of reulceration, the fact that it's expensive, the fact that there's a risk of operative morbidity, and so on. Similarly, medical therapy has advantages. It avoids surgery, which is a major advantage, potentially avoids hospitalization, preserves more of the foot. And under the disadvantages, you can see that there are several issues related to the fact that there are a number of complications of giving long-term antimicrobial therapy. The second table that we put together, and I did this with a consultation with a number of my colleagues who are interested in diabetic foot osteomyelitis, is to say in which situations would it make sense to go first to medical, and in which situations would it make sense to go right to surgery. And you can see here the ones that we selected. For medical, the patient is too medically unstable for surgery. They might have poor postoperative mechanics. There's no other surgical procedure that's needed, so there's no other reason to do surgery than to remove the osteomyelitic bone. Infections confined to a small forefoot lesion, we think that medical therapy is easy there. Surgery costs are prohibitive for the patient, and the patient may have a strong preference to avoid surgery. On the surgical side, you can see that if the foot infection is associated with substantial bony necrosis, we may as well go ahead and remove the bone. That's not going to be very helpful. The foot appears to be functionally unsalvageable. The patient is already non-ambulatory, and so on. You can read the others. So, Dateline Tourcoing, France. I bring this up because a very nice study that was presented by Eric Senneville at the IDSA meeting last year. He looked at the duration of treatment for osteomyelitis of the foot in diabetic patients. He did a multi-center randomized controlled trial comparing 6 weeks versus 12 weeks of antibiotic therapy for diabetic foot osteomyelitis. Not yet published, but here is the preliminary results that he presented. At 5 centers in France, patients were followed for at least 12 months after the end of their treatment. Patients with diabetic foot ulcers without ischemia and no surgical treatment were selected. Diabetic foot osteomyelitis was diagnosed by X-ray and bone culture. Clinical remission was on the basis of the factors that we usually use. And here are the results. Among 40 patients enrolled between 2007 and 2009, the characteristics of the two groups were similar. The overall remission rate was 65%, and if you compare the 6-week 60% cure with the 12-week 70% cure, given the small numbers, this was not statistically significantly different. So I think what we know now is that you can treat some patients with diabetic foot osteomyelitis with surgery alone, and we have some rules for how to select those patients, and you can treat them for relatively short durations of therapy, no more than 6 weeks. So I think we've made some real advancements. So in summary of my BBC report, under Bones, Diagnosing Osteomyelitis, we talked about the potential benefit of new imaging methods, the implications of the presence of osteomyelitis. We talked a little about gram-negative osteomyelitis, treating osteomyelitis, Under the biopsies, I spoke a little about the Codify study and the new information we're getting from comparing swab and tissue cultures. And under cultures, I spoke with you a little about the new microbiology and the variation of microbiology by geographic area. So thank you very much, and that's your BBC report for tonight.